Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam, a cardiologist from Houston, Texas. The cardiology seminars are brought to you by Triple N Media. Our YouTube channel has more than 200 lectures on various cardiology topics. We welcome you to watch them, and we also kindly request you to subscribe to our YouTube channel. I have created a cardiology rotations manual for nurses, medical students, residents, and for cardiology fellows, a great resource for learning a great deal during your cardiology rotation during training. I'll tell you how you can get a copy of this at the end of this presentation. The featured presentation is a cardiac patient and non-cardiac surgery risk assessment. So you're seeing a cardiology consult on a floor. A patient is going for gallbladder surgery, or a patient is going for hysterectomy, or a patient is going for colectomy, or a patient has an aortic aneurysm which needs to be resected, or going for brain surgery. How do you evaluate a patient with cardiac problem as to what is the risk for this patient to undergo the surgery? What kind of surgery are we talking about? And what are the medications the patient is on? And what kind of complications we can expect during surgery and immediately in the perioperative phase. I'm going to be focusing mostly on coronary artery disease. There are a lot of different varieties of cardiac patients we see in our practice, but 95% of our patients are of the coronary artery disease and its complications type. So I'm going to be primarily focusing on the coronary artery disease, patient evaluation, and getting them ready for surgery. When we are dealing with a patient with coronary artery disease, we need to be also concerned about complications following surgery. I'm going to be talking about, we need to look at what kind of cardiac procedures this patient had. Did this patient have stents? Did this patient have bypass surgery? Did the patient have a pacemaker? Does this patient have any other procedure done with reference to the heart, like valves surgery, things like that? What medications the patient is on, especially blood thinners. Since we are doing surgery, we need to be concerned about bleeding as a major problem. Then the next question is, what type of surgery are we talking? Is this a low risk, medium risk, or high risk surgery? Perioperative complications. No matter how well we evaluate a patient for pre-op risk assessment, there's always going to be some kind of complications following a surgical procedure. One time I was attending a renal transplant conference, and they said 100% of their patients undergo cardiovascular evaluation, and still 10% of them would end up with cardiac complications such as hypotension or renal ischemia due to hypotension, or atrial fibrillation with rapid ventricular response, or some degree of myocardial ischemia. So we cannot totally exclude any cardiovascular risk, but by evaluating these patients in a systematic manner, we can identify some of these issues, address them, and minimize any perioperative complications. Because these patients are receiving anesthetic agents which have significant cardiovascular effects, no matter how well we prepare them, they could come out of the surgery with volume overload, salt overload, hypotension, hypertension crisis, or any other conditions that we may have to address as cardiologists and staff. Then perioperative management is one of the most challenging things. I dealt with cardiac surgery patients for more than 30 years at the Texas Medical Center between 1980 and 2015. So I have seen all kinds of perioperative complications, from atrial fibrillation to hypotension to hypoxia, renal failure, and deep venous thrombosis, pericarditis, you name it. We've seen all kinds of stuff. That's why I think it's important for us to keep our mind open and be cognizant of the fact that we can see any type of complications, no matter how well we have screened the patient before the procedure. When we are talking about a patient with a coronary artery disease, I'm going to give you some very important coronary artery disease focused approach to evaluate how is this patient now. The question is, how long did this patient have coronary artery disease? What kind of symptoms is this patient having now? Does the patient have chest pain? Is it exertional? Does it suggest angina? Or do we need to be concerned about it? Shortness of breath. It's another indication of heart or lungs. If this patient had heart failure, we need to assess how significant the shortness of breath is. Can the patient walk 2 blocks, half a block, or can he walk inside the house? All these things are important. It gives us to assess their functional capacity. Palpitations, another important aspect of cardiovascular examination that may relate to PVCs or it may relate to arrhythmias like atrial fibrillation, atrial flutter with rapid ventricular response. So the rate needs to be controlled before surgery, during surgery, and after surgery. And does the patient have edema? A weight gain that may suggest decompensated heart failure. See, the moment we see a cardiac patient, we need to start looking at all these different parameters so that we truly have a picture of what is going on inside their chest in the cardiovascular system. Does this patient have history of myocardial infarctions? Stents. How many stents does this patient have? Where are the stents located? When was the last time this patient had a cardiac catheterization? And how many bypasses were done? What bypasses were done? When was the last time the bypass grafts were checked? How many bypass grafts are open? Did the patient have a pacemaker or an ICD? Does the patient have a prosthetic valve? Is it a bioprosthetic or a mechanical valve? Because the mechanical valve patients may be on blood thinners, and that may be a very significant factor before we send someone to surgery, especially if this patient has been on warfarin. Next thing is heart failure. A lot of patients with coronary artery disease have heart failure, and when you're talking about heart failure, you need to find out, is it systolic heart failure or diastolic heart failure? Both of them have a significant effect post-operatively, because these patients are subjected to so much volume in terms of 2-3 liters of saline, which adds a ton of salt into the system, and especially the diastolic dysfunction could put these patients into pulmonary edema with a flash, with a blink of an eye. So we need to assess the left ventricular ejection fraction. When was the last electrocardiogram? When was the last echocardiogram done? What was the thickness of the LV chamber? What was the size of the left ventricular chamber? Was there mitral regurgitation, aortic stenosis, pulmonary hypertension, tricuspid regurgitation? All these things need to be put together to make a composite image, replica, like a hologram of your patient in your mind, so that you know how this hologram is going to behave during and after the surgery. Does this patient have chest pain? And does the electrocardiogram show ischemic changes? How significant is the chest pain? How are we going to evaluate the chest pain? Does this patient need a stress test, or did this patient have a stress test recently? How long ago was that? Arrhythmias. I talked about arrhythmias, especially atrial flutter or fibrillation with rapid ventricular response. Weight is an independent risk factor for surgery in cardiovascular patients. Same thing with diabetes, chronic kidney disease. Even though we are cardiologists, we need to document all these things. How much was the hemoglobin A1C? How is the patient on insulin? Is the patient on dialysis? What is the patient's creatinine level? Creatinine level is very important because a lot of cardiac drugs are metabolized through the kidney, and if these patients don't get dialysis or they can't pee the medications, then they can develop toxicity. Again, you have to have a complete list of the medications, including the names, dosages, frequencies, and any side effects. Okay, let's move on to the next aspect. We need to do a functional assessment of these patients. The patient may be lying in bed, they may be hardly moving, and we cannot assess this patient's functional capacity. How robust is this patient to undergo a surgery, even if it's a hernia surgery? How do we assess that? We ask simple questions. Can you climb a flight of stairs? Can you walk around in your neighborhood? If they can do it, they have a 4 METs capacity. If they can hardly do anything in the house, that means they 1 MET. So they have very poor functional capacity. And these patients are the ones who are going to be bedridden following surgery. They are prone for developing deep venous thrombosis or pulmonary embolus, the worst of which. And also, if they can get around the house, clean the house, sweep the house, and pick up the garbage and climb stairs, there may be 4 to 10 minutes, which is a reasonably good amount of functional reserve. But if the patient is playing sports, jogging, all these things, they are in very good functional status. It's almost like they have passed a regular treadmill test. And these patients fall into a low risk category. Next, physical examination. When we are doing physical examination for a pre-op clearance, we have to pay attention to all cardiovascular organs. We need to look at their jugular venous pressure to see if they have increased jugular venous pressure. Feel for carotids. Listen to the carotids and see if they have any bruit. If they have a bruit, you better get an ultrasound test before you put them to sleep, because the surgery may be successful, but if the patient comes out with a stroke, that's not good for you or the patient or the family. We need to look for any scars, bypass surgery, pacemaker or valve surgery. And next thing is we need to evaluate their heart function, especially if they have a history of heart failure. And if they are having symptoms of shortness of breath, fatigue, weakness, definitely need to get a full, complete echocardiogram to evaluate their left ventricular heart function. We also need to look at their electronic health records. That's the first thing I would do even before seeing the patient. Look at their electronic health records. Make a summary of all their admissions, their procedures, their interventions, medications, allergies, so that you have a complete composite picture of what has happened before, even before you begin to sit down with the patient and talk. Next, do we need any electrocardiogram? Most patients will end up getting an electrocardiogram. Do they need an echocardiogram? Here's a sticky point, especially if you are taking cardiology boards. Echocardiogram is not indicated for every patient if they are not having symptoms or no evidence of heart failure. So you need to be prudent in ordering echocardiograms. If at all, just look at their electronic records and see what their echocardiogram findings were. If the ejection fraction was normal, if the wall motion was normal, there's no need to repeat an echocardiogram. But that's like a board question. Stress test. When would we do a stress test? If the patient has chest pain, abnormal EKG changes, which are new compared to the previous one in the electronic records, then you may be concerned about, does this patient have ongoing myocardial ischemia that is reversible? If there is a situation like that, then we need to be able to identify that by doing a nuclear stress test. Since most of these patients cannot exercise, we just simply do a chemical stress test using a nuclear scan or an echocardiogram. But you need to look for any evidence of reversible myocardial ischemia. If there is evidence of reversible myocardial ischemia, and if the surgery is a major one and it's an elective one, like getting a hysterectomy 3 to 6 months down the line, you need to further evaluate that reversible ischemia, perhaps do a cardiac catheterization and see if there's anything that needs to be done in terms of interventions. Arrhythmias. Arrhythmias are a big pain dealing with perioperative patients. Everything goes fine. All of a sudden, their heart rate jumps to 200. Atrial fibrillation. Now you have to know what drugs to use, what drugs this patient was already on, what has worked in the past, and how do you bring the heart rate down. Same thing with atrial flutter. Medications. Medications are important because a lot of times these patients may not be getting the medications they are supposed to, especially on the surgery day. And I'm going to talk about that in a minute. The most important thing we need to be concerned about is blood thinners like warfarin and then antiplatelet agents. If the patient has a stent, if they are on antiplatelet agents, or if they had a recent stent, then the whole ball game changes. I'll cover that in a minute. Okay, tests. When we do the lab test, we need to focus on cardiovascular related issues like CBC, electrolytes, potassium, magnesium, liver function tests. Why do I need liver function tests? Patients with heart failure may have elevated liver function tests, and when they come out of surgery, if they are in shock, their liver functions may shoot, and you want to know if these changes are there before or are these changes new. Same thing with kidney function. Creatinine level need to be very closely monitored. We are cardiologists, but we need to monitor creatinine level because all cardiac drugs needs to be adjusted based upon serum creatinine clearance. BNP may suggest how bad the heart failure is, how decompensated it is, and it is an independent risk factor for outcomes in patients going for moderate to high risk surgeries. Chest x-ray. Most cardiologists are not in the habit of looking at chest x-ray, but I would say make it a habit to look at chest x-rays, because there's so much pathology that we can detect on chest x-ray which echocardiogram and EKGs are not going to tell us. If the patient has cardiomegaly, pulmonary vascular congestion, effusions, calcifications, or pneumonia, atelectasis, all these things will add up to the risk of this patient going for surgery. So don't leave any corners unturned. Next, we look stress test, as I indicated before. If a patient has a pacemaker, you better get the pacemaker checked, because we need to make sure the pacemaker is functioning. Number two, we need to see how we can maybe put this pacemaker into a fixed rate if we have to during surgery, especially if they have to work close to the pacemaker site, and if they're using electric cautery, then we need to look at coagulation studies, PT, INR, and see if the patient is on warfarin, when was the last dose taken, and what test steps have we taken to make sure that the patient's warfarin has been replaced with unfractionated heparin or heparin to bridge the gap. If the patient has reversible ischemia, then you may be even talking about cardiac catheterization and perhaps intervention. Of course, when you do intervention, you're putting a new stent. Now the whole ball game of surgery rolls down for months, almost to a year. We'll cover that too. Oh, okay, this is my nuclear lab when I had my office back in the 80s and 90s, and that's the nuclear camera I use, and we were able to get excellent nuclear images. So that's something of historic note. Here's a chart showing the relationship between BNP and 30-day mortality. If the BNP was 0 to 250, the 30-day mortality in surgical patients was 6.6, which is still high, whereas if the pro-BNP was 0 to 300, it was 1.8. But look at this, if the BNP is more than 400, then the 30-day mortality or MI was almost a third. So you better monitor the BNP, and if the patient has elevated BNP, look for causes of decompensated heart failure, optimize the patient before you send them for surgery. Otherwise, you are asking for trouble. Atrial fibrillation, I already mentioned about atrial fibrillation, but atrial fibrillation is a real troublesome accompaniment of cardiac patients, because perioperatively they give a lot of headache with just jumping up with the rate, and you try all kinds of drugs, you can't bring them down, and it compromises cardiac function, it reduces cardiac output, and makes the recovery prolonged. Look at this. If a patient simply has a coronary artery disease, the risk is 2.9%, whereas if the patient has atrial fibrillation, the risk is 6.4%. Can you believe that? A patient with atrial fibrillation has more risk following surgery as compared to a patient with just coronary artery disease who is stable. So don't ignore atrial fibrillation or atrial flutter. They are just cousins, bad cousins. Okay, let's talk about cardiovascular medicines. Which one do we keep? Which one do we stop? Which one do we put on hold before the procedure? First of all, remember, when I was working for the VA, we had a whole basket full of medicines. At least average of they were on 20 different medicines, half of which of them were cardiac actually. And the other half is non-cardiac, but they may have cardiovascular effects, and so you have to look at the whole basket. Well, we need to continue their anti-anginal medicines, beta blockers, statins, aspirin. In some cases, that's an individual decision. If we start beta blockers for control of rate or for blood pressure or for anything else, make sure the beta blockers are started at least a week or two before the elective procedure, so we know how this patient responds to these beta blockers and has a steady level of beta blockers. You should not ever start beta blockers one day before surgery or on the day of surgery if the patient was not on beta blockers. I mean, you can give short-acting intravenous beta blockers to keep the rate down, but I wouldn't start oral medications if the patient was not on until we know the patient's condition is stable. Of course, we need to hold diuretics, hypoglycemic agents, digitalis, ACE inhibitors, antiplatelet agents, and warfarin. All these need to be put in your checklist so that you don't miss any of these. Because if you miss warfarin, the patient gets a warfarin the day before the procedure and comes with an INR of 2.0 and then it goes for abdominal surgery and the patient is bleeding, guess who is going to get to be called? Yes, you. Here's a little flow chart that was put out by the American Heart Association, American College of Cardiology, the consensus on perioperative risk. And I'm just going to go through this very, very briefly. If the patient is scheduled for surgery with a known or risk factor for coronary artery disease, we are talking about patient with a history of coronary artery disease. If this is an emergency surgery, you just stabilize the best way within the 2 or 4 or 6 hours you have and go ahead with the surgery. If the patient is on warfarin, you need to reverse that with medications and switch him over to heparin when it is appropriate, and the surgery has to be done if it's life-threatening. So there's no contraindications for a life-threatening surgery, even if these patients are on antiplatelet agents or anticoagulants or any other medications. Okay, now the patient is not going for an emergency surgery. The next question is, does this patient have acute coronary syndrome? This I already touched about. That's why we take in the history. Do you have chest pain? Do you have shortness of breath? Do you have palpitations? Do you have dizziness? Do you have syncope? All these are points leading towards analyzing and see if this patient has acute coronary syndrome or decompensated heart failure or uncontrolled arrhythmia. So when you pinpoint all these things, it helps to determine what to do. So here, from there, we go to the next step, which is on the next slide here. Okay, we're coming down here. Let's say we estimate the risk for major adverse cardiovascular events based on the clinical surgical risk assessment. We saw all those things in the previous chart here. Like if we have excluded acute coronary syndrome, so this patient is supposed to be stable with whatever cardiac condition they have, be it just coronary artery disease, stents, bypass surgery, or a compensated heart failure. Okay, if they are in this category, if they are low risk, that is, means risk less than 1%, we don't need any further workup like echocardiography or stress tests. They can go for surgery. On the other hand, if they are in the intermediate risk, I'm going to show you the next chart in the next slide. What are these surgical candidates who are low, medium, and high risk candidates? So if that is the case, and if they have moderate to greater than 4 METs functional capacity, if they are able to perform 4 METs of activities, then we see, if they are between 4 and 10 METs, more than 10 METs, no further testing is needed, they can proceed with surgery. If their capacity is between 4 and 10 METs, no further testing is indicated. This is class 2B indication for them to proceed with surgery. However, if they have very low functional capacity, then we need to find out if it's less than 4 METs, what further testing we need to do to differentiate these patients. If these patients cannot exercise, then we can do a pharmacological stress test. If the pharmacological nuclear stress test is normal, no evidence of reversible ischemia, they can be optimized medically and sent to surgery. Whereas if they have an abnormal stress test, then they need to go ahead with cardiac catheterization and see what needs to be done. If they have more than 4 METs, they can be maintained on medical treatment and they can go for surgery. Okay, this is about coronary stent. This is a very important slide. Let me just briefly go over this. If the patient had a coronary stent within 4 to 6 weeks prior to surgery, if this is an elective surgery, You preferably would like to hold the surgery for 365 days if the patient had a drug-eluting stent and keep them on dual antiplatelet agents. Whereas if the patient had a metal stent, then we need to hold off the surgery for a minimum of 30 days. If there's no elective surgery recommended, you continue with dual antiplatelet agents. On the other hand, if the patient had a drug-eluting stent, but they can't wait for 365 days, 1 year, then the risk of surgery needs to be weighed against the risk of stent thrombosis. And based on that, it is a clinical decision. We have to make a decision. They can go for surgery within like 180 days and hopefully keep the duration of taking out the antiplatelets to minimum. So you resume the antiplatelet agents as quickly as you can, or use some intravenous medications to bridge the gap. If the procedure requires discontinuation of this P2Y2 inhibitors, if there's no need to interfere with that, we can continue with the antiplatelet agents. If it has to be stopped for any reason, we can keep them on aspirin and restart the antiplatelet agent as soon as the condition dictates. Okay, there are various kinds of surgical interventions we come across. One is an emergency surgery. A patient is in the ER, we have to take them to the OR because they have a ruptured aneurysm or something like that. We don't have any time for any monkey business. So you just quickly look at their electronic health records, see what's there, look at the current lab tests, and look at the vital signs and proceed with the surgery. If it's urgent, 6 to 24 hours, we may be able to do some limited functionality tests like a stress test if we have 24 hours. And if it can wait for 6 weeks, it is something that we really need to take into account and do a thorough cardiovascular evaluation. And if it's not an emergency, then you just wait for a year, especially if they had a drug-eluting stent. Then it also depends upon the type of surgery. Is this a high-risk surgery like doing thoracic aneurysm or AAA, where a lot of vascular changes happen during surgery, or a peripheral vascular surgery? When we are dealing with a high-risk person, the mortality is greater than 5%, so we need a thorough examination and evaluation of their functional status and hemodynamic status before we can clear these patients for surgery. Even after that, remember, we can still have problems with arrhythmias, hypotension, infection, things like that. Intermediate risk is somebody who goes for a carotid surgery, head and neck surgery, or an orthopedic surgery like a knee replacement, hip replacement, prostate surgery. Still, they have less than 5% mortality. It's not 1%. So we need to pay attention to what their cardiovascular risk is. On the other hand, if this patient are going for endoscopy procedures, surgical procedures, cataract surgery, they have less than 1% risk. And if they have a stable cardiovascular condition, if their electrocardiogram looks okay, not different from the previous one, and they are not having any symptoms, we don't need any further testing, even including a stress test, and they should be okay to undergo the surgery. And there's another way to look at it, that is, we not only focus on the heart, but as a cardiologist, we should be concerned about the risk factors: hypertension, diabetes, smoking, high cholesterol, chronic kidney disease. They all add up to the overall picture of increasing the cardiovascular risk, and that's what this slide is talking about. You can read it. So how do we manage these patients intraoperatively and postoperatively? Do we need an arterial line? It depends upon. If it's a high-risk patient, yes, an arterial line is okay. A central venous pressure line is okay. PA catheter, it depends upon the institution. Some institutions, everybody gets a pulmonary artery catheter, the Swan-Ganz catheter. Some institutions, they don't put that even in cardiac surgery patients. So it's just a matter of preference. And nowadays, most intraoperative transesophageal echocardiography is very readily available to all patients with cardiovascular problems going for thoracic aneurysm surgery or lung resection, so they can assess their left ventricular size, volume, and fluid status. So follow your institutional guidelines as far as these lines are concerned. Remember, the Swan-Ganz catheter or the PA catheter has not shown to alter the outcomes in patients in the intensive care unit following surgery. Okay, perioperative complications. We need to be concerned about perioperative complications as a cardiologist, because you are the only person who is knowledgeable enough to put all these pieces together. Your internist, a good doctor, cannot put all these pieces together. The surgeons cannot put all these pieces together. The nurses cannot put all these pieces together. You as a cardiologist, staff or a fellow, is the only one, because you need to look at the fluid intake. If you see abdominal surgery patients, they get 3 liters of normal saline. Do you know how much salt is in 3 liters of normal saline? 27 grams of sodium. And you think about giving 27 grams of sodium, where the normal sodium intake should be less than 2 grams per day. What happens to a patient with renal failure, or what happens to a patient with diastolic heart failure? No wonder that patient is in pulmonary edema in the intensive care unit as he is being rolled in from the surgery. So pay attention to the or the operative notes. How much fluid was given? How much blood loss was there? What kind of arrhythmias did they have? How long did the patient have hypotension? All these things add up. If the patient had hypotension, they could have developed myocardial ischemia or even STEMI, or they could have developed renal insufficiency. These things play a significant role in the post-operative phase. In the post-operative phase, you had to deal with hypotension due to blood loss or volume loss. You had to deal with hypertension crisis. You deal with pulmonary edema, which I talked to you about. Always remember, diastolic dysfunction will give you more problem than systolic dysfunction, heart failure, because diastolic dysfunction takes maybe a liter of fluid to put them into pulmonary edema. Atrial fibrillation, not a very good friend to be around in the perioperative phase. Same thing with VT, VF, volume shifts. All these things are important. When do we resume their cardiac medications? As soon as it's feasible. And we are, as a intensivist or cardiologist, we need to be familiar with inotropes, beta blockers, vasopressors, diuretics, and vasodilators. All this, I have a separate video on most of these topics. You're welcome to watch them, so that it will bring the whole gamut of cardiovascular acute care management into focus, so you can be a better informed consultant dealing with pre-op cardiac evaluation and management. So ladies and gentlemen, this is a very, very quick overview of how you evaluate a cardiovascular patient. How do you assess their risk? How do you calculate their functional capacity? How do you rule out reversible ischemia? And how do you optimize their heart failure, arrhythmias, and all these things? And what is their risk when going for surgery? And what things we can expect during surgery, and what things we can expect after surgery, and how well we are going to be prepared to address those issues. Thank you so much for watching this presentation. Please do subscribe to our YouTube channel. And if you would like to get a copy of my cardiology rotations manual, please send me an email to drniknikam@gmail.com, and I will be happy to send you a copy of that one. This cardiology seminar has been a presentation of Triple N Media. I am Dr. Nik Nikam, a cardiologist from Houston, Texas. Thank you so much for watching this presentation, and please do subscribe to our YouTube channel. I will see you in the next video.